Hi, this is Dr. Kevin Kirby, coming to you from Northern California. And this lecture is going to be covering the first part of the medial and lateral heel skive technique. First of all, let's define the subtalar joint, mid-tarsal joint, and midfoot joints. The subtalar joint incorporates the talus and the calcaneus in the rear foot. Mid-tarsal joint is those joints between the talus and navicular and between the calcaneus and the cuboid. Midfoot joints comprise the Lisfranc joint, navicular-cuneiform joints, navicular-cuboid joint, and the intercuneiform joints, and the cuboid third cuneiform joint. The first research on the subtalar joint came from John Manter in 1941, which he took 16 cadaver feet and looked at the orientation of the subtalar joint relative to the sagittal and transverse planes. And he found that on average, subtalar joint was 16 degrees medially deviated from the mid-sagittal plane and 42 degrees upward oriented from the transverse plane of the foot. However, Manter's study did not determine the exact entry and exit points of the subtalar joint, but rather its medial lateral deviations and also the upward angulation of it relative to the transverse plane, or its relation to the plantar foot. Later research by Isman and Inman also looked at cadaver feet, 46 of them, found the subtalar joint was oriented 42 degrees from the transverse plane and an average of 23 degrees adducted from the sagittal plane. Again, they did not determine the medial lateral position of the subtalar joint axis relative to the plantar foot. The big breakthrough in subtalar joint research came from von Langelaan in 1983, in which he used this rig where he took and rotated the tibia in 5-degree increments medially laterally, so internal and external rotation of the tibia, producing subtalar joint pronation and supination. He implanted steel beads into the cadaver feet, into the tibia, talus, calcaneus, navicular, and cuboid. And at each point, he was able to determine the actual orientation of the bones and then the motions, and from there, the subtalar joint axis location. And what he found compared to the earlier researchers was that the subtalar joint was not a hinge-like axis, but rather changed position in what they called a bundle of axes. So when the subtalar joint moves from pronation to supination and from supination to pronation, it actually is shifting position slightly. As we see in this diagram here, we have the subtalar joint as it moves from pronation and supination. The axis location actually changes slightly, but it produces a bundle of axes so that we now have eliminated the idea that the subtalar joint actually is a hinge joint, but rather it is more a moving hinge depending on the relative rotational position of the subtalar joint. Research has shown that the subtalar joint axis actually has a relatively constant anatomical exit point anteriorly and posteriorly. Anterior position as much has been researched more, showing that the subtalar joint axis passes out through the anterior midsection of the dorsal neck of the talus. And so that when we go into pronation and supination, showing here, the subtalar joint axis, because the talus moves medially and internally rotated with pronation, and as it supinates, it externally rotates, so does the subtalar joint axis rotate with the talar head. So we see in the subtalar joint pronate position, the talus is, and the axis is medially deviated. When the foot's just slightly pronated from neutral, it's approximately over the sesamoids. And with supinate, it actually externally rotates and laterally translates relative to the ground. In 1984, and during my biomechanics fellowship at the California College of Podiatric Medicine, I started experimenting with this technique where I would push on the plantar aspect of the heel of the foot. And this idea came with a private discussion I had with Dr. John Weed, who was one of my professors. And he had indicated he would use this technique to try to determine how far he would have to push the heel medially with his thumb to determine how much pronation control the resultant orthotic would need. And so I basically put the patient on the table in a supine position. I would use my thumb to align the forefoot parallel to the patient's transverse plane. If I push medial to the subtotal axis, I would feel subtotal joint supination with my thumb. If I push lateral to the axis, I would feel subtotal joint pronation with my thumb. And if I was right on the axis, or what I would call later the point of rotation, that was the plantar location of the subtotal joint axis. And this was published in my 1987 paper in JAMA. The subtotal joint axis passes in the normal foot from the posterior lateral calcaneus to approximately the fibular sesamoid or the first intermetatarsal space. And this is something that I found in feeling the feet of hundreds of individuals over the first few years I started doing this technique, finding that the feet that function normally always had their subtotal joint axis passing out through the posterior lateral calcaneus to the first intermetatarsal space or fibular sesamoid. As a result, when we start seeing then this correlation of subtotal joint axis to mechanical pathology, I also started to see that pronation-related symptoms such as posterior tibial tendonitis, posterior tibial tendon dysfunction, sinus tarsi syndrome, and this type of pathology would always have a foot that had a medially deviated subtotal joint axis. If I had a patient who had a lateral axis, many times these feet were not a flat foot like we see in the medial axis, but it was a high arch foot. And these patients may be suffering from peroneal tendinopathy, may be suffering from chronic peroneal tendonitis, or may also be suffering from chronic inversion ankle sprains. However, in the feet that function most normally, I would see the subtotal joint axis, because the tatus was pointing now through toward the first metatarsal head, a normal axis location passing out approximately over the fibular sesamoid and out through the posterior lateral calcaneus posteriorly. So pronation-related symptoms had a medial axis. Supination-related symptoms such as peroneal tendinopathy, chronic inversion ankle sprains tended to have an axis that was laterally deviated. So what are the mechanical effects of this medial and lateral deviation of the subtotal joint axis? If we start looking at ground reaction force, indicated here, here's ground reaction force under the calcaneus and ground reaction force under the forefoot. In a normally positioned axis, we have ground reaction force causing a subtotal joint supination moment, and we have the ground reaction force underneath the lateral forefoot causing a pronation moment. How as that subtotal joint axis shifts medially, we start seeing that we lose the ability of this ground reaction force under the calcaneus to produce a supination moment and greatly magnify the effects of ground reaction force on the forefoot to cause a pronation moment. The exact opposite occurs, though, in the laterally deviated axis. In that laterally deviated axis, we have now the moment arm for ground reaction force under the calcaneus causes an increase in subtotal joint supination moment. And now the ground reaction force underneath the lateral forefoot causes the decrease in pronation moment. So we see that as the subtotal joint axis shifts medially laterally in space relative to the plantar foot, we start seeing that we have an effect on the moments, supination moments and pronation moments acting across the subtotal joint axis. And this is going to affect the overall moments in addition to muscle reaction forces and ligament tension forces. Here again, we see the subtotal joint axis having a shortened moment arm at the calcaneus with the medial axis and have a lengthened moment arm with the lateral deviation of the axis. So we can see how this shifting of the subtotal joint in space relative to the plantar foot and ground reaction force is going to cause an alteration in the moments acting across the subtotal joint axis during weight-bearing activities. Muscle tension forces are also going to be affected by this shift in subtotal joint axis in space. Medial axis is going to shorten the moment arm for the supinators, such as the posterior tibial, and lengthen the moment arm for the peroneals to cause pronation. The lateral axis is going to increase the moment arm for the anterior tibial, posterior tibial Achilles tendon to cause a subtotal joint supination moment, and decrease the ability of the peroneals to cause a pronation moment. In a normal axis, though, we see that the anterior tibial, posterior tibial, Achilles tendon are all medial to the axis, which will produce subtalar supination moment, and the extensor digitorum longus, peroneus ternus, peroneus brevis, and even the peroneus longus will tend to produce a pronation moment. So we get to the next step in the equation of understanding how a medial heel skive or lateral heel skive works, and this is this concept of rotational equilibrium, where in the subtalar joint maxillary pronated position, when we start adding more pronation moment to the system, it is not going to pronate further. And this is a special situation in that normally when we have a subtalar joint, we add in a supination moment, we're going to go to neutral first and subtalar joint supinated. But when we add a pronation moment, we're going to go from subtalar joint supinated to subtalar joint neutral to subtalar joint maxillary pronated. But once it hits that maxillary pronated position, additional subtalar joint pronation moment is not going to cause further pronation, but rather cause an increase in force in the sinus tarsi, possibly producing the symptoms we know as sinus tarsi syndrome, which are caused many times by excessive subtalar joint pronation moments acting across the foot. So let's look at a common example of posterior tibial tendon dysfunction. This is a patient of mine who had posterior tibial dysfunction on the right foot. And we can see how medial that axis was, whereas the left foot, which was asymptomatic, had a medial axis, but not as bad as the right one. We can see the right side having more medial positioning of the tatus and the subtalar joint axis, pointing more inward, whereas the left foot has less of this effect. We can also see a child here that has a medial axis. Normally the axis should be passing out through the first metatarsal. And we see here in this flat foot that this axis is not passing out through the posterior lateral calcaneus to the first metatarsal, but rather is passing more through the navicular. So that we see these feet that are this pes planus feet in the pediatric and adult deformities, they're always maxillary pronated, the subtalar joint, causing this pronated appearance and also this medial deviation of the subtalar joint axis. On the other hand, laterally deviated subtalar joint axis tend to have a cavus foot, metatarsoductus, or even extreme amounts of rear foot varus. And as such, this will produce a lateral positioning of the subtalar joint axis. Instead of being through the posterior lateral calcaneus to the first metatarsal, it's quite lateral. Here's a gentleman, a patient of mine, who had chronic peroneal tendinopathy. You can see the medial convexity that is common with these lateral axis feet. And we can see the inverted heel, and we can see on the left foot the extreme supination of the foot in a resting calcaneal stance position. These patients will always have tonically active peroneal muscles during standing in order to prevent full supination of the foot. And as such, we oftentimes also develop calluses plantar to the fifth metatarsal and to the base of the fifth metatarsal. And we can see another callus here on the fifth metatarsal of the right foot. These are the points on the plantar foot that are resisting the excessive supination moments and causing, therefore, increases in ground reaction force in this area. So in conclusion, we need to understand this positioning of the subtalar joint axis in space relative to the structures of the foot, including tendons, ligaments, muscles, and ground reaction force, in order to understand how biomechanically these changes in subtalar joint axis causes a change in the biomechanics of the foot, including the magnitudes of pronation moments, the magnitudes of supination moments, and the balance of rotational equilibrium that can occur with these changes in subtalar joint position. So understanding the significance of spatial location of the subtalar joint axis and the dynamic motion of the subtalar joint axis during weight-bearing activities allows us to better understand and appreciate foot biomechanics. And when we start talking on the next lectures about the medial and lateral heel skive, these concepts of subtalar joint axis location and rotational equilibrium will become much more clear as to how these orthotic modifications greatly aid in producing improved gait in patients who require such modifications to treat their pathologies and to improve their gait function. Thank you very much for your attention, and I hope that you enjoy this lecture series.